Jonathan, another exciting topic, the topic of pediatric dentistry and the future of dentistry, and how do we make the business case and the operating model and the clinical model of practicing dentistry work, especially in rural areas that need it the most.
It's amazing. And I'm so excited to have Dr. Johnny Norris, who is really figuring out how do we get to a wellness model? How do we treat our young patients? And that's where we really have to go. We have to get to the young people so they don't develop these dental diseases of decay, breakdown of the hard tooth structure, and gum inflammation, and get to healthy habits and get to the diagnostics and using our new technologies. He has created a business model in his 5 offices as a pediatric dentist without doing aggressive dentistry. Really very conservative approach. I'm so excited for our listeners to hear what he is figuring out.
I'm excited about the questions. I can't wait to ask you and Dr. Norris about the new ways of treating caries and maybe even curing the infectious disease of caries rather than going after it invasively. And I really can't wait to hear about the next set of myths that we'll be busting around treating kids and Medicaid patients and rural care. Is rural care that comes at a lower cost necessarily lower quality, or could it also be cutting edge innovation?
And we have that level playing field. That's exactly right, Maria. And breakthrough products that are remineralizing teeth like Curadont, the amazing product that now has insurance coding, SDF, all of these new products that are creating remineralization of teeth without having to drill. Let's get to Johnny Norris and hear what he is doing with his team. So excited.
Get to it.
Okay.
Hi, everyone, and welcome to another exciting episode of the Think Oral Health podcast, where we connect the dots between medical and dental care teams. As usual, I'm joined by my co-host and thought partner in crime, Dr. Jonathan Levine. We're happy to have you today.
Excited to be here.
Yes, Jonathan, we have a very special guest today, and I have the privilege of introducing Dr. Johnny Norris. Dr. Johnny Norris is a pediatric dentist. He's co-owner of Montshire Pediatric Dentistry in New Hampshire. He's also a captain of the United States Air Force. And with that, he's actually been exposed to so many community health outreach events for children and volunteering to provide dental care to the underserved pediatric population. He did that all as part of his active duty service, and his volunteering has really helped him discover his calling and passion for working with children. Dr. Norris is really special dentist because he's able to combine doing good for the community with doing well as a practice co-owner. And he's also a medical staff member of a number of hospitals. And that helps him have a unique perspective and makes him a really exciting guest and conversation partner for us. So with that, Johnny, welcome to the podcast. We're so happy to have you.
Honored to be here. Thank you for having me.
Awesome. So you are our first Air Force captain on this podcast. You are also a pediatric dentist who is doing something really special in our view. You are the person who takes care of thousands of kids that need care, and you're doing it in a very lean model. You have only about 3 dentists in your practice, and you're allowing them to operate at the top of their license. So what's the magic? How are you able to do that?
Yeah. And to be clear, I am out of the Air Force right now. I was a captain, a dentist. What makes this a little bit different is that we look at dentistry quite differently than the way we were taught. I did 2 residencies. I did one at the Air Force Academy as an AEVD, and I did another one through NYU in Alaska. And I was taught to look at dentistry as very much traditional drill and fill. What we look at dentistry now very, 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 very differently is we look at, the disease as an infectious disease. And I know that you cannot drill your way out of an infectious disease. And so what does that mean? It means that there's medicines that are available now that weren't available even, 8 years ago in our country that allows you to medically manage a disease process, which allows us to practice less invasively, more efficiently. I would argue way more fun. It's also cheaper, and it also creates an abundance of access. So we started the practice in 2018 with 11 patients. And fast forward today, we have over 20,000 patients. We have 5 practices actively, 4 in New Hampshire, 1 in Maine, and we are in the process of opening another one in Vermont. And we have 2 more coming down the pike. So we have 8 practices with 3 dentists, because what we're finding is we're using these medicines, we're actually eradicating the disease. And so when I went into dental school and I went into this profession, I really wanted to fix the problem, not necessarily work on the problem. And there's a huge distinction between the two. And so right now I am watching us stabilize populations. When our practices are 50 to 70% Medicaid, we never put a limit or a cap on the amount of children that it's not a child's fault for their financial situation they're born in. And we've never turned a kid away because of their financial status. And what we're finding, though, is I'm becoming more and more irrelevant. And what I mean by that is we're stabilizing populations once they get on the program and we've rehabbed them. There's not much more disease to manage. And so that's where I'm a really high energy guy. And I go out to these different communities because I have to go places where my services are needed. And so in Key, New Hampshire, for example, right now we have over 10,000 patients in that clinic, but arguably it's only maybe 2.5 doctor days. And it's because there's no dental needs for me. Like there's no operative for Johnny to do. And so that's a great thing. That's a win for the community. However, I can't just sit around. So, it's a long-winded response, but that's, I think, in a nutshell, what we're doing.
It's amazing.
Johnny, let me jump in for a second, because you're touching on something that is so important for all of healthcare. Maria and I are so committed to breaking down the walls between medicine and dentistry. And one of the biggest problems in medicine is the sickness model. The fact that there's a lack of focus on going upstream and how do you get to the early stage or the wellness approach so disease doesn't happen, right? And you're touching on something, and you're really focused on something that medicine could really learn from, is how do we get upstream? How do we create this wellness model? We know in the mouth it's 2 processes of demineralization or remineralization. And I'd love you to kind of explain, especially, to the listeners that are clinicians and practitioners, but also running organizations. How do we create that effective model, knowing what you know and what you've learned, the difference between what you learned in dental school and what you've learned once you got out of dental school, of how do you get upstream on that wellness approach?
Yeah, and I can look through the traditional lens. I went to a residency where at the time I was told informally I had done the most operative procedures of any resident. I was in the operating room every single week and putting kids to sleep. And so it's not lost on me that's how we're trained and how we look at these sort of problems. When I look at kind of our model looking upstream, I could break it down into really, it seems very self-evident to me at this point. But I think there's really 4 principles in our practice that really helps us achieve better outcomes and a win-win for just, our practice and our livelihood, our profession, but also for our patients and community. So one is just prevention, right? And so we talk about prevention, and I got to give a lot of credit to hygienists because I think they really pick up on this way more than doctors or dentists and maybe even physicians. Part of the problem in our model, not my model, but the model in the United States and greater, is that the bigger the problem, the more we get compensated. And so that we're incentivized to be fixers and to look at a really, really, really big problem. And all of a sudden, I'm going to go and if I have to do, 8 implants and crown, I'm going to get paid way more than if I use some medicine to sprinkle on a tooth. When I first started the practice, the reimbursement rate for, I'll talk about this medicine, silver diamine fluoride. It's a holy water. It's incredible. It's done so much in our practice and around the world. But I got compensated 15 times less than doing a filling for that. So there's a perverse disincentive to look at that. However, if you look at prevention and if you look at, just medicine model and you look at dentistry, for over 100 years, we've just jumped straight to the surgical model. And when I say surgical model, I'm talking about drill, fill, remove endogenous tissue. Versus if you went to your PCP, you had an infection in your knee. If your PCP said the first thing we're going to do is cut out your knee and put a piece of plastic, which is what a filling is, or a piece of porcelain or what a crown is, you'd probably say, I'm going to get another doctor. So I think from a prevention standpoint, we need to be exhausting all of the different medicines and jump to the most invasive options as an option of last resort. There's many arrows in the quiver, but I think as dentists, we either just watch something until it becomes a big problem before we just treat it with other sort of, like you talked about, remen and demen. You can actually remen and your body can actually heal all sorts of lesions. And I'm talking about cavities, caries process, but prevention is one piece. Another big piece is education. I can't tell you how many times I see parents or patients that their minds are blown when they're like, well, I eat really healthy, Johnny. I don't have any sugar. We don't have any soda. We don't have any candy. And I go, well, it's actually, fermentable carbohydrates. And they're like, what? And I'm like, oh, actually, goldfish, in my opinion, cause more cavities than anything at this point. And they're like, oh my goodness. And so then all of a sudden we start talking about diet. We start talking about, it's a motivational interview. That being said, we talk at an eighth grade level because this is very, very, very complex processes. However, if you really want to enact change and you want your message to be heard, you got to talk to the layperson and speak in language that they understand. So basically, a lot of education, because I can break it down in about 2 minutes, explain it, and I find moving forward that all the patients get it. But it's basically, if you talk at a very high level and you really want to enact change, you're probably talking to deaf ears, and it's going to fall on deaf ears, I should say. So education is another big piece of it. Another big piece is the research. So I'll say I did 2 residencies, and the way I'm practicing now is radically different than the way I was trained. And it's not because we're bad people, and it's not because, dentists are bad or not keeping up, or sometimes maybe we're not keeping up. But there has been so much literature that has come out proving and saying that we could be using all sorts of different modalities to be able to treat an infectious disease. And so when I first started practicing like this, I'll be very honest with you, I didn't know communities like you existed. I didn't know Dr. Hayes existed. I just read the research over a weekend. I read over 60 articles, and I changed the practice overnight because I was very convicted, and I was like, there has to be a better way to practice. Now I feel very validated in seeing all the research that's coming out and continues to come out. And I feel very, very, very strengthened and emboldened. However, just because you are taught a certain way is not a good rationale. Our patients deserve better, I guess is what I'm saying. So research. Lastly, I think the other key component to this is you got to check the ego at the door. So doctors, I've been in very practices. I've worked over 20 different industries. I come from a very blue collar background. And so, I've worked in places where people in power will make rules for thee and not for me. And they don't check the ego at the door. And so just because I have a DDS or a whole bunch of alphabet soup after my name doesn't mean I'm better than you. And what I mean by that is I have hygienists that are extremely gifted. I have assistants that are incredibly socially apt and have high emotional IQs that can reach patients in a way that I can't. Why wouldn't I take advantage of that? So in our practice, if the Board of Dental Examiners have very specific guidelines which allow people to be able to practice at a very specific level of their scope. We know that inside and out. I actually have a dental lawyer right now reviewing all of our processes to make sure we're doing everything. I know we're doing everything within the book, but I actually want to push it a little bit further. That being said, if a hygienist is certified to be able to place silver diamond fluoride, they should. If an assistant's allowed to, they should. If we're all calibrated, which we have calibration exercises, and it's very, very intense, but we do have manuals for that, there's no reason why they can't be practicing, because what it does is it shorts me up to do the things only that Johnny can do. At this point, I would argue 85% of what I do can be outsourced and delegated to other staff. The 15% are the abscesses or the infected teeth that have to come out, or the crowns that I have to put on for the kids to get, because of the rampant decay, the big holes in their teeth. So that's what's happening right now. And so those are really the 4 pillars of the practice.
Yeah, we love that, right, Maria? Maria, now let's connect the dots, because Johnny, you're creating an efficient business model because you're utilizing a full team, building culture. So I guess, Maria, we have to ask the question is how does this impact equality of care? Where we have underserved population, maybe it's Medicaid reimbursement, and you've been able to crack the code because of this new business model. Tell us, what have you found?
Yeah, and just to that point, for our listeners who are avid listeners of our podcast, we had the CEO of Benefits, Brian Carey here, who shared with us that for every Medicaid dollar that you earn, it's 75 cents on the dollar relative to commercial rates. And so they were also able to create a business that was thriving and sustainable with Medicaid patients, not discriminating against what type of insurance you have. But it is a little bit more challenging than purely going down the commercial path or private pay path, right? So tell us how it works for you in your 8 practices.
I'm going to say it's the great equalizer. And so like when I'm talking about these sort of things, I talked about state insurance. However, I would argue this is the gold standard of care. I would argue this is not third world care. I would argue what we're doing is not anything. It's quite frankly, it's the stuff I do in my children's mouth and in my mouth. So I would say that as far as equality, it allows access to everybody. And so the medicines, so much of this can be this infectious disease can be treated with medicine. And so much of this disease does not require quite a bit of technical expertise. You're allowed to use people that have much lower training levels and certifications. You know, I was in school for 12 plus years post high school. And so I've gotten to this point in my career, I should only be doing the things that only I can do. So I think we've manufactured a lot of barriers with the medicine, and I think there's barriers that are being broken now. However, even to your point, Maria, you know, the commercial insurance, you know, 75% is actually really good. Most of the time, you know, with the CDC, I've read that it's about 49%. However, the way we make up for that is we incentivize prevention. So like you incentivize prevention by using medicine. So now all of a sudden, if you incentivize medicine, because quite frankly, I don't want like I say Novocaine because, you know, everyone always thinks that's local anesthetic. Novocaine's antiquated, but I don't want a shot in my mouth. My 5-year-old certainly doesn't want a shot in their mouth. A 60-year-old doesn't want a shot in their mouth. If we can treat things without giving injections, without invasive things before it becomes a major problem, that's outstanding. However, that only takes 2 minutes. Yeah. Whereas if you block a quadrant dentistry, you might be scheduling that for 45 minutes. It's not uncommon for me to meet a patient that drives 2 hours away because there's no access. I see them, do the bite wings, do the treatment planning, talk to them about everything we're talking about, get buy-in, and do a full mouth dental rehab in 20 minutes. Whether it's, you know, doing all the glass, which is a type of restorative material, whether it's silver diamond fluoride, whether it's betadine or povidone iodine, or whether it's crowns, and all of that without local anesthetic. So that's how you do it.
Yeah. And it's interesting because the key to what you're describing is the ability to truly optimize every single member of your team. And you alluded to pushing the boundaries of what's currently possible. And I appreciate, our listeners would appreciate that you are also operating in New England, you are in Maine and New Hampshire, so there are different scope and licensure regulations that you're dealing with. But Dallas, at the moment, for you, you're amongst friends here because Dr. Levine has been talking about the hygiene room as the tip of the spear of innovation for any dental practice. It sounds like you're exactly on the same wavelength. So tell us how you are organizing your team and how you're operating your practices to make the most out of every single member of your medical team and dental team.
We have very strict training manuals, and we have very strict calibration manuals. And so, you know, there's 3 dentists in this practice, and I've worked in group practices prior to owning this business. And you would get it, you know, the classic cliche is you go to 10 different dentists, you get 10 different treatment plans.
Of course, yeah.
And right. However, I would argue that we're all lockstep. Why? Because we're using science and we're using research. We're using, 2018, the ADA came out with this scientific affairs came out with the ICAT system, the classification, and when you should treat lesions and when you should not. It's very easy. I know that hygienists cannot diagnose caries. I know that assistants cannot diagnose caries. However, they can see if there's a hole in the tooth. They can see if there's shadow. They can see these sort of things. And can they diagnose this? Absolutely not. However, are they instrumental in knowing how to be able to look at all like clinical situations and help us come up with a treatment plan that is best suited for the patient? Absolutely. So I wish there was like more to the secret sauce other than we have manuals. We sit down, we have training. We go through all the different algorithms. There's actually decision trees. If this, then this. If this, then this. And the other part of this is also including the patient, or like when I say patient, also the parent, because there's the agency. One of the things that we learned in dental school, I learned in residency, was no treatment is always an option. And I think sometimes we forget that. So I'll let you know, part of all our training, there's probably about eight different types of treatment options we always give. When we talk about the risk benefits alternatives, we actually go through them. Some of it's not applicable because, I'm not offering sedation very often anymore. Quite frankly, out of the 20,000 patients we have, I've done one deep sedation day in the last 10 months. And it was 4 cases. So when I say deep sedation, IV sedation, like borderline general anesthesia. So this is working.
And I mean, for our listeners, what you're describing is really where dentistry is going, and it's pioneers like you who were curious enough to go in and read the literature. It's interesting also to note that out of the universe of what you call medicine rather than interventions, invasive interventions, there are new products and solutions coming to market. There's a new code this January, taking effect this January, 2991, that is also intended in, along with SDF and glass ionomer sealants and other options, to intervene early, right? And remineralization and enamel regeneration is a possibility. So you talked about patient agency. Most patients are not deep in the weeds the way we are and don't know that there's a new code and there's a new solution and there's, no treatment is an option. So what is your advice for patients to increase that agency, to get educated before they go to the dentist? Where would they go for credible information on this?
That's a tough question. I don't think we're there yet. So the reason I say that is, why am I in Maine? I'm in Maine because, and my website's terrible. We're updating it right now. But we had patients that looked this up and drove 3 hours away because they learned that there's medicine out there, and they heard on some sort of podcast such as this, or they heard about from another sort of like word of mouth. Exactly, a month ago on a Friday we had a patient from Texas, a patient from Virginia, a patient from Massachusetts, all within 2 hours that flew. And I'm not pumping anything, so I'm not pumping any of this information out there. And so I'm not really answering your question other than I think it's people like you. I think that, the reason I'm talking to you, I'm generally a shy person. I generally am not
You could have fooled us, Johnny. I don't know what you're talking about. You could fool it.
Oh man, I get so anxious about this sort of stuff, but it's more about the message because kids are suffering. And quite frankly, I'm a pediatric dentist and I'm looking through the pediatric lens. Everything I'm saying translates to adults. And so that's the other thing, because I'm seeing a whole bunch of people right now suffering and not getting taken care of and falling through cracks when we have all sorts of medicines now that we can take care of people. And so I think it's people like you. I think there's other networks that are going on. So there's a network out in Oregon. I was out in Oregon 3 weeks ago with a bunch of dentists that are committed to it's called Equity Dental. And they're committed to working with Medicaid and tackle the adult Medicaid problem. And they're a group of dentists that were part of Advantage Dental, ex-Advantage Dental guys that basically were serving 600,000 Oregonians that were on state insurance at one point. So I think that's just one small little cell of people that are doing what they're having to do. But I do think, Malcolm Gladwell talks about the tipping point. And the tipping point is when we get to a certain amount, the critical mass of awareness, and then all of a sudden it's going to happen very, 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 very rapidly. Overnight, things will change. And you're talking to a dude that's just I'm in rural New Hampshire, and now I'm in Maine, and I'm in Vermont. I'm if I can do it, your pedigree is outstanding. And people that are listening to me, they're CEOs of billion-dollar companies. If this little guy, this little nobody from New Hampshire is able to take care of this many people, absolutely, this is the way it's going to change. And I sound bombastic when I say this because my staff and close circle hear me say this all the time. I honest to God believe we can cure this thing in three generations.
Wow.
And it's all about education. And you got to do it though, because that's the other thing. I said this early on the podcast. There are two types of people usually. Do we want to fix the problem or do we want to work on the problem? And when we work on the problem, those are the type of people that want to have a meeting, They set up the meeting, discuss the solution, then have the solution, but then they have a problem. And 4 weeks later, they decide to have a meeting about the proposed solution and they get decision paralysis, right? And then we don't go anywhere. And then indecision becomes a decision. Whereas like I'm a guy that kind of embraces the chaos and I'm a humanist. I care about people. That's why I'm doing this. There's too much suffering and I know too much to not push the envelope. Because I do think that by large and far, I think dentists have really good heart. And I think they got into this for the right reason. I just think through the delivery mechanism is skewed and we're never going to fix the problem if we keep doing the same solution, which we've been doing for over 100 years. And I think we're losing that. And I think it's simple. Yeah.
Johnny, let's jump in on that a little bit. Let's jump in a little bit about that. You know, you read those 60 articles on a weekend, you just said, and literally you came back to your practice and you took action. And to me, that speaks to mindset. That speaks to the ability to take action. Yet we know in the medical and dental profession, it takes 17 years for adoption of new technologies. So what would you say to your professional colleagues from what you learned in dental school to what you learned after dental school, to the actions that you've taken, to the impact you've had on your communities and these young patients that don't develop these much more serious dental diseases because you've been able to get to root causes and drive more of a wellness model? What could you say to them to get them on board, to take that 17-year adoption rate way down and to adopt your mindset?
So I am here for that reason, Jonathan. So you're not relevant until you're relevant. And so when I had 11 patients 5 years ago in Keene, no one would listen to me. However, I'm pushing the envelope right now, and I keep doing this because I'm on a podcast talking to you incredible people. There's no way I would have dreamt of doing something like this. So what I'm doing is I'm trying to provide a model and let people know there is a different way. And so I'm trying to empower them because, quite frankly, I hear all the time that, well, we can't accept Medicaid because you can't be financially viable. Well, that's a fallacy. I'm living proof that you can do it. And so I'm here as living proof to show, okay, if you're saying that, you're saying I don't exist. Clearly, I exist. And so clearly this model can and will work. So more than anything, I think we're all afraid, right? We all have different fears that why we do things and why we don't do things. What's driving me right now is I know too much. And I'm afraid, I think that I've been given a lot, and I'm very fortunate for how much I've been given. But for those who have been given a lot, there's a lot of responsibility. And so this is where I'm okay, I got to go out there. Even though I'm sick to my stomach, a lot of times I'm really living in the uncomfortable realms of life in our industry. But I have to know I'm on the side of right. And I know I'm on the side of taking care of people and patient care and really looking for, again, this is a win-win for everybody. However, if you're looking through the old model, a fear would be, well, okay, yeah, reimbursements are so low. I can't make it work this way. Well, yeah, if you're going to practice the same exact way that you've been practicing, it's not going to work. But you got to think outside of the box. And you got to think outside, okay, there's actually options that you can do and be able to serve this population. Just don't do it the same way that you've always been doing it, because the way you've always been doing it hasn't been working. And so I guess that's what I would say to that. Does that make sense?
And John, what are the changes that you immediately put into your office after that weekend, that inflection point, and then you made changes because it's a much different business model, right? You're not really looking to put people under sedation. You're not looking to do all of that drilling. You're really going to more of this preventive model. Did your offices, did you need more treatment rooms? Did you have to hire more hygienists? Did you create new protocols and systems? What exactly did you do as we kind of get a little more granular and you could talk to the profession? Say, what are the things that you really learned that made this huge impact?
The thing that I learned, right at that time period, what I learned was silver diamond fluoride. So that's 2017. Silver diamond fluoride was the game changer. And so all of a sudden, I started treating all the lesions, all the E1, E2 lesions, D1, D1 to the DEJ. I was treating with SDF. I've actually become more radical at this point because I've seen it work, where I've actually seen it work as far as D2 lesions, where if you use silver diamond fluoride enough, you actually can remineralize and strengthen and heal the lesion. And so at that point, I really started using silver diamond fluoride as the first like go-to option. I also overnight switched over from resin to glass ionomer. And so from why did I go to glass ionomer? So glass ionomer is actually like it's on the WHO's list of essential medicines. And even before I back up, I want to give a shout out. One of the catalysts for that change is I went to a CE event in 2017 on a Friday by Dr. John Fercella. John Fercella was speaking in Burlington, and I went with one of our hygienists, and I was just sitting there with my jaw dropped because for 6 hours straight, I couldn't believe what I was hearing. And it was like in the Air Force, we had a saying, trust but verify. And so I wanted to believe the man, but I was also like, how in dental school and all my residencies, I'd never heard of any of this sort of stuff. So I do want to give that man credit because he was the one that kind of pushed me in this direction. So that being said, silver diamond fluoride and then glass ionomer, because all of a sudden, like I can let you know, I was a dental dentist for 4 years before I went back and specialized in peds. So I can look through the lens of a general dentist. And when I was going through pre-med, I remember the med faculty or the pre-med faculty asking me, why did so many dentists commit suicide, Johnny? And I was like, I don't know. Like, I have no idea. And I thought that was like not like maybe necessarily legitimate. After being a dentist, it's tough. I understand we are trained, like we're judged on fractions of millimeters. And we're working in a very inhospitable environment that's moist, and we're using things like resins that are supposed to be completely bone dry. And then all of a sudden you do your damnedest, like your heart, like to do your best work. And then all of a sudden a year later, things are failing. And it's like, you feel like I wanted to help this person and I failed you. Potentially, you can take that on. Glass ionomer chemically bonds to the tooth. There's no interface. So that bond, when we use bonding agents, it doesn't hydrolyze. And so it actually helps, like there's lots and lots of studies that show why that's much better of a material. But I also remember this 2015 podcast with Dr. Gordon Christensen, and he literally made the comment, and it was with Dental Town, and he said, "You're not going to like this, but resins are actually slightly carcinogenic." When he was talking about amalgam versus resins, and he's like, amalgams are cariostatic, but resins are slightly carcinogenic. And so as a doctor, I'm like, okay, do no harm, Johnny. And if I'm actually putting materials in people's mouths that are carcinogenic, time out. So the silver diamond fluoride, the glass ionomer, and then I started learning more about studies about povidone iodine and betadine. So then we started introducing betadine and povidone iodine in the mouth. So this is me also letting you know, at that time, I didn't know how to monetize any of these sorts of things. I didn't know much about CDT codes. I didn't know much about I just knew that I could buy a bottle of betadine for $4 off Amazon. And I also knew that for that $4 off Amazon, I could take a drop and I could paint it on kids' teeth and I could teach parents how to use it. And I know that if they start using that, they can actually arrest, the studies vary, but it varies anywhere from 40 to 60% carries arrest. That's one of the most, when you talk about dental quality and equity, that's one of the best and first things that we should be starting at is like everyone should have a bottle of betadine. It's easy. You can get that in any pharmacy or like CVS or Amazon.
No, that's exciting. It's really exciting.
Also, Johnny, could you, especially as you talk about silver diamond fluoride and all these other options, could you please again highlight the role of consent and education and the parents' awareness of staining, education, maintenance, because these two go hand in hand, right? And we've heard on this podcast people on both sides of the spectrum, right? In Europe, silver diamond fluoride is not allowed to be used in children because of the silver, because of the staining. So I want to make sure that we are raising awareness of the role of the patient and appropriate use at the end of the day.
Yep. So everything we do, we have consent with all of that. We go through, when I talk about the second pillar is education, that is a big part of it. I will say this, you can probably tell that I'm very impassioned about this subject matter. I care a whole lot. I am a full-fledged believer in all the products and all the medicine that I use. So why is that important? I'm not peddling anything. I'm not a charlatan. I'm not a snake oil salesman. I believe I use the products in my mouth. So what does that mean? The parents know that what I'm telling is coming from my heart and it's palpable. They can tell on a just very visceral level, wow, Johnny believes in these sort of things and he's speaking truth. So when we talk about the black staining, I can let you know, probably I can't like because I probably go through a jug of SDF a month. I would say that I'd never ever get any pushback on it. However, I am not using silver diamond fluoride on the anterior piece.
Exactly.
So I'm not stating the aesthetics. So
That's right.
one of my favorite applications is using it in the posterior interproximal on those like very small incipient lesions. Love using it right there. Povidone iodine in the anterior. However, I've had a handful of parents in 10 years that have wanted me to actually use it in the front, and I show them, 10 different like really scary pictures. They see it and they still want it. That's fine. But that goes back to the agency point. Like, okay, they know this is what this is going to look like. We're going to manage the disease like this. They care more about managing the disease with the silver fluoride than the aesthetics. I can't fault that. I'm not judging you. I can rally behind that.
And there are other options and alternatives that keep coming up.
That's exactly right. I mean, we have this whole new breakthrough science with peptides that are happening now. There's a new insurance code 2991 that is showing, a deep dive of the research and the science. You know how hard it is to get insurance companies to back reimbursement. And obviously these type of technologies, whether it's peptides, whether it's SDF, with any of these, once the insurance companies understand that they're going to save money, it's proven that the science and the research is supportive to that. That's back to the upstream model because, as we know, 20% of our GDP is spent in healthcare, and that's the sickness model, and that's has to change. And here we are in dentistry, and someone like you is a pioneer in pediatrics who is driving this upstream model, and we have to start with the children. We have the Glow Good Foundation, and we go down to a Lutheran. And it's a microcosm of what happens when there's no nutritional education, no oral health education. Nobody's going into the schools. You're stuck with your modern diet. There's no farm to table. There's no farming. And here, there in Eleuthera, it was 8 years ago when I got down there with the team, an oral health disaster and a general health disaster of diabetes and inflammatory diseases. 8 years later, I would say, because of the people that are working together, and it's from Harvard Public Health, BU, NYU Public Health, Nova Dental School, 100 volunteers. We go down there, and Maria joined us, and we're in the schools. We hit every school. We have a freestanding clinic. Thank you, Henry Schein, 14-chair freestanding clinic. We're going to bring more teams down there during the year, but we see the impact of how we can get upstream with prevention in the schools, and then also the impact we can have on the community by bringing their mouth to a healthy status, removing the decay and the inflammation. And we're measuring that. Here you are, you're treating these young children, you can measure it. And I think the more you get the word out to both our professional colleagues and the community, the more that this concept of what you've learned and what you jumped in on and didn't delay 17 years and built your teams around this thesis, how you're able to create this wellness model, this less expensive model, this more efficient model where everybody wins. Everybody wins in your model. Wouldn't you say?
100%. One thing I would say to that, in my profession, I was trained to do a lot of hospital dentistry and sedate children. On average, depending on what state you're in, it varies per case, $8,000 to $12,000. I can't tell you how many times I have parents that come for a second opinion, and the treatment plan, and a lot of them is Medicaid, but it is private and commercial as well, that it actually ends up being maybe $200-$300. And so when we talk about the problem, here's the issue with the problem, is that so we go fee for service, and we go, okay, we don't want to accept Medicaid because we don't get paid enough. So we go to the state and we go to the government and say, you need to pay us more. But I'm going to tell you, the government has no more money. The state has no more money to give us. So if what I just told you, in each one of these children's cases, we're saving the government 50 times X, like per child per case. On top of it, we're able to see much more children because of this. So now we've created all the access. So when we talk about, access issues, I hear that. I only believe we have access issues if we look through the traditional model lens. I actually don't believe we have access issues if we start practicing through the model and through the lens I'm speaking about.
Wow, that's
Right
amazing.
there. Right
Love
there.
that.
That
Love that.
is-
Highlight bells and whistles. So on that point, right, when we practice the dentistry of the future, preventative, personalized, minimally invasive, we also practice the solution we solve the problem around access. We don't work on it, to quote you, Johnny. I loved my time at Eleuthera because I was able to see the impact Jonathan and the team of volunteers were having on the lives of the local community. What I also noticed is that within hours, they were able to take a community center that also doubles as the church and turn it into a highly functional OR, hygiene room, dental office with throughput that would any high-end clinic would be envious of it, right? Over 100 patients every day, and there was still a line out the door. What was so amazing was not only the heart that every dentist and every member of the team put on in that room, but also it was pretty high-tech operation, okay? From digital fabrication, fully digital workflow. I was amazed. I asked so many questions. I'm like, I feel like I'm an expert. At least I appreciate the enormity of it. But technology was a key component of the magic that Jonathan and the rest of the dental team were able, and medical team, nurse practitioners were part of the magic. So Johnny, talk a little bit about the role technology plays in the model of care delivery that you're putting forward. And yeah, we touched on the clinical side. Talk a little bit, if at all, right? And I know, Jonathan, you have an opinion, so I want to get your thoughts on it too.
Yeah, for what we're looking at is probably the biggest piece for the technology is teledentistry. So teledentistry has a huge undiscovered, or untapped market resources, and we're developing those sort of things now. So what I mean by that, like when you're talking about schools, or when you're talking about mission trips, or when you're talking about churches, like all these different public health, alternative public health settings, if you don't have to have a dentist there, but you can have an intraoral camera, or
That's
if you
right.
can have these medicines, or you can have, and any of those sort of things. So I think teledentistry is a big piece of this because I think it has amplifying effects. Now, from just another technological standpoint, our innovation would be, I think 3D printing has a really big place in the future. I think 3D printing, I was talking to, we're talking about Harvard, and I'm very grateful for Dr. Catherine Days. She put me in touch with one of the pediatric dental residents I graduated from, and he was showing me.
Dr. Catherine Hayes is the Dean of Public Health at the Harvard School of Dental Medicine, a great friend of the program, and also a supporter of all the humanitarian work that Jonathan has been doing. So kudos to the work that this team is doing. So anyways, go ahead, Jonathan.
Yes, thank you. Thank you for that. He was showing me photos where, a child had trauma, cut off, basically fractured 8 and 9, your 2 front teeth, and did endo, but then within 10 minutes was able to 3D print a crown.
Wow.
It was incredible. And I'm looking like, okay, I talked about glass ionomer as a restorative material. I would love to be able to 3D print glass ionomer restorations because I think that's a game changer. So when we talk about, you brought the staining of silver diamond fluoride. Well, what if I could do SDF and if I could 3D print some sort of like veneer with some sort of opaquer? Now all of a sudden that is not a concern anymore. We can manage this disease, and now we're being very reactive because we're having to paint silver on the front teeth. But if you could 3D print any sort of like prosthesis, that's incredible. It's actually really cheap as well. So when we get back to equity, and we're talking about managing disease processes in populations, so adult Medicaid, where you have rampant decay. Well, what do? We got to get the disease under control first before we jump to the restorative. So knock the infection back, paint the medicine, get the disease under control. Okay, well, somebody has to work. We have to function in society. We don't want people to be judged. You have to have a smile line. Okay, well, what if we can actually print very cheaply prostheses very quickly with no, you understand?
And it's already happening. Dr. Levine and his team did that. It's exactly what we're talking about. So
that's it.
Here, Jonathan. Yeah.
Yeah, no, look, this is, I'm a prosthodontist, and, in our practice, we have a team of specialists and 3 ceramists, complete digital workflow. But we took that digital workflow to Eleuthera. And with the help of Alexander Bendian, who's the head of prosthodontics at Nova, who used to be at Boston University and brought digital dentistry to BU, and now Nova is
They're all
very
better.
fortunate to have someone like Alex. So I have Alexander Bendian. We have an amazing group from NYU also. We set up scanning, designing, manufacturing. So with 3D printing dentures and partials and prosthesis, something that takes a day to do 1 or 2, we now do 6 to 8 in an hour and a half. We're printing and we're designing on computers in a Lutheran. And it's fascinating to see how technology can level the playing field where there is inequality. And I believe that's exactly what you're doing. You're taking the latest research in science. You're applying it to your thesis of how do I treat patients more conservatively, minimally invasive type dentistry, going upstream and being preventive. And you've created a model that's more efficient, cost-effective, and better for the patient, because we know natural tooth structure is the best tooth structure to have. And I believe that also as a prosthodontist and one of the first people in the country to do porcelain veneers in my late 20s, that you got to be conservative. And my whole thesis and methodology of teaching and practicing prosthodontics is that mindset of how do we do things minimally invasive. And that's where dentistry is moving. But we got to move it because it is a little bit like the Titanic, as we know. And it's these kind of conversations, hopefully, that we could motivate and we can generate interest within our industry. And most importantly, with our young clinicians who are coming out of school, of what those schools are teaching and educationally. So my last question, because I know we're running late, but my last question is do you see what you've learned? Can you see it becoming fundamental in the education of dental students and pediatric programs?
Yeah.
Absolutely. It absolutely has to, and it will. And I think it was like 2000 when the Surgeon General Satcher was the one that made the connection between the mouth and the body.
Yes.
I graduated dental school in 2010. So that was already a part of the curriculum. I'm talking to dental students now that are embracing, and new grads that are embracing what I'm talking about. I'm going to make a joke right now, but the most unethical thing I've ever done in my profession was getting my license. What I mean by that is I prepped an E1 lesion on a live patient for an amalgam, right? And so knowing what I know now, I should have never done any of that. I'm glad that we moved away from the live patients and prepping teeth that we know that can remineralize and heal itself. But absolutely, I think that because they understand that all of this is connected and that this is not divorced from the rest of the body, they are much more prone and willing to understand it and accept these sort of things. I think that in education, though, we're in a weird mullet phase. And what I mean by that is I still have this, like the clinical skills to get crowns on a raging bull. Like I've got a 3-year-old that's moving around and I have to have really proficient technical skills to get these crowns on this kid. If you are just painting medicine all day long on kids, you might not feel as comfortable after, being able to get that treatment rendered. I've done 10,000 plus stainless steel crowns on a kid and I can do it in my sleep. However, if you don't have that sort of experience, that's going to be a little bit more difficult. And I think that's where we're like generationally, I think it's still good to have, like I said, it's a continuum. I think that it's really good that I have such a good surgical background to be able to rely on. However, I'm also understanding in the communities and the established practices that I have, those skill sets aren't really needed as much anymore. It's more going to the places that haven't been served. But I do think that but I guess the question I would have then to you, Jonathan, is do the educators actually want that? Because that's a scary proposition. The scary proposition is I'm trying to put myself out of a job because I want to heal this disease. For 3 generations, I think this can be done. And so the question is, there's an inherent bias, self-preservation of not wanting to fix the problem, because if I fix the problem, what am I going to do?
Yeah. That fear, unfortunately, drives everybody, whatever industry you are in. That is the notion of change. And we know that it takes courage to change. And if you have that courage to make a change and you're not worried about the almighty dollar, what does happen is everybody wins because you create a unique value proposition for people. People are coming from all over the country to see you because they understand that there's a more conservative approach. So the adoption of this thinking is going to happen in the educational level. And it's the leadership, as we all know, like every organization, it's the leadership that is going to help create that change. Because if you're a faculty that is resistant to change, it's never going to get down to the student level. So it has to be adopted in the leader. And I saw that at Boston University when I was the chairman of the board, working with Jeff Hutter as the dean. And he drove digital dentistry, and he drove these new things into this, into the school. And Dr. Bendayan made sure that all of the faculty was on board, because if they weren't, it would have never gotten to the student level, and it did. And that's positive. And I offer that as an example of what has to happen educationally. You have to get the buy-in. Well, Maria, this has been just an amazing conversation. We can go on and on and on, but it's so exciting because, Johnny, you are right in the thick of things. You're in the weeds on this, but you're really building a beautiful organization. And this, your thesis and what you've learned, you're taking the action, and you have the courage, yourself, to make these changes and to go against the conventional thinking that was taught in dental school. So
ultimately,
I really applaud that.
Yeah, and thank you for reminding us that all of us, irrespective if you're a clinician, if you're on the business or investment side like myself, or if you're running an education institution, the real question is you have to decide, what business are you in? Are you in the business of treating sickness, or are you in the business of maintaining health? And if you're in the business of maintaining health, then you're going to have a different operating model and a different business model and a different longevity, I believe, in this industry than if you're in the business of treating sickness. And so with question in mind,
agreed.
We're very grateful to have you. Thank you, Johnny. And until next time, because we're very excited to have you back, and maybe you could share all the new things you've learned and the new ways you've evolved your practice of dentistry.
Thank you so much for having me. It's an honor and a privilege. Thank you.
Thank you, Dr. Jonathan Norris. You're amazing. Maria, like always,
It's always a pleasure
to share this with you.